This segment covers several viral illnesses that matter for athletes, campuses, teams, and public health. Some are resurgent because vaccination rates have slipped in certain groups. Others are, like rabies, rare but so serious that delay can be very dangerous. The common theme here is recognizing the pattern and then acting appropriately. Let's take a look. Measles and mumps are two vaccine preventable diseases that remain clinically relevant. Even though many times we think of these as childhood diseases, we continue to see resurgences, including in school age and college age populations. That is especially important for athletic trainers, clinicians, and anyone working with teams or campus communities. Both measles and mumps are protected against by taking live attenuated vaccines. But vaccine protection depends on adequate coverage and, in some cases, appropriate boosters. If vaccine coverage drops or if immunity is incomplete, these infections can reappear in settings where people live, study, train, and socialize closely together. For measles, one of the classic early findings is Koplik spots. These appear on the buccal mucosa inside the mouth. They're considered pathognomonic, meaning if you see them in the right clinical context, they strongly point toward the diagnosis. Measles can also produce a morbilliform rash, upper respiratory symptoms, conjunctivitis, sore throat, photophobia, and a fever that increases over several days. If someone was previously vaccinated, the disease may be modified and less classic, but it doesn't mean that it should be ignored. Mumps is best known as an infection of the parotid glands. We see classic swelling is often bilateral, and the area may appear smooth and enlarged around the jawline. Mumps is spread by respiratory transmission, and it has an incubation period of about 2 to 3 weeks. One of the major concerns, especially in older adults, is orchitis. Because of swelling and pressure within the testicular structures, mumps orchitis can threaten fertility. The key takeaway here is that vaccine protection matters. Boosters also matter to re-up on immunity. And these diseases are not just historical concerns because we might be seeing resurgence in college or athletic populations. Measles and mumps should stay on the radar when it comes to signs and symptoms and exposure history fit. Influenza virus is an important respiratory virus for athletes, teams, and campus settings because it spreads efficiently and it can affect performance very quickly. Influenza is transmitted primarily through respiratory droplets, which is why close contact environments matter. Locker rooms, classrooms, buses, team meals, shared housing, these can all increase opportunities for spread. So this slide is meant to remind us that influenza has animal reservoirs, especially birds and pigs, and this matters because animal reservoirs can contribute to new influenza variants. When different influenza strains circulate between animals and humans, the virus can change in ways that affect immunity and vaccine effectiveness. The timing is also important. Influenza A has an incubation period of about 2 days, while influenza B may incubate closer to 1 day. During that early window, a patient may already be infected and possibly contagious, but they may not even know it and they may not look sick. Well, they may not have yet developed obvious red throat or severe cough or clear clinical findings yet. And that makes influenza difficult to control in group settings because people can spread the virus before everyone recognizes what's happening. Clinically, influenza often presents with fever, headache, sore throat, cough, and general feeling of being run down. One classic symptom is myalgia. That means muscle pain. When patients say they feel like they were, quote, hit by a truck, end quote, that is often related to the cytokine response. In other words, some of what makes influenza feel so miserable is the immune system responding to the infection. Testing can include fluorescent antibody testing or PCR testing. This is often from a nasopharyngeal swab, and the timing is important because early recognition can guide treatment and isolation decisions. Antiviral treatment can be most effective when started early, ideally within the first 48 hours. It doesn't instantly cure the flu, but it may shorten the duration of symptoms and help the patient recover sooner. The practical point here is that influenza is not just a bad cold, but rather it has fast clinical rhythm, spreads efficiently, and can affect athletes before obvious signs are visible. Early recognition, appropriate testing, vaccination, and keeping symptomatic individuals away from team settings are all important parts of prevention and management. Avian flu, bird flu, right? These are caused by with avian influenza, and classically may be represented with a type A virus. So all of these are good to keep in mind as we're working with a patient population that has high risk exposure due to the community environment. There are some other gut viruses that are of importance to discuss, especially norovirus and rotavirus. The organizing principle here is fecal-oral spread. In practical terms, that means the virus is shed in stool, and it then reaches another person through contaminated hands, food, water, surfaces, or close contact settings. Norovirus is one of the major causes of adult gastroenteritis. It spreads very efficiently and can remain on environmental surfaces, which is why outbreaks are so common in close quarters. Cruise ships are a classic example, but we also can think about areas like where teams are going to spend time, in the dorms, in the locker rooms, in shared travel environments. Once one person is sick, it can move quickly through the group, especially if hygiene and surface cleaning are poor. Rotavirus, that's classically associated with pediatric gastroenteritis. It also spreads by fecal-oral route and can cause significant fluid loss. One important difference is that rotavirus vaccination is given early in life as an oral vaccine, which has helped to reduce severe disease in kids. Both of these viruses, we see that treatment is usually pretty supportive. The priority is hydration and prevention of fluid loss. If someone has vomiting or diarrhea, they need to replace fluid and electrolytes sensibly. Something like an oral rehydration solution, sports drink, that might be best. Something that's slightly diluted with water may be one of the more practical options for mild cases, especially when the goal is primary fluid replacement. The referral clue here is important. If symptoms persist, if the patient can't maintain hydration, if they become weak, lightheaded, or if blood appears in the stool, we should not delay, and it should be noted that referral might be necessary. We shouldn't just assume that these are routine viral illness when we start seeing other signs and symptoms manifest. Those findings warrant medical evaluation. Our takeaway here is that gut viruses are usually self-limited, but the setting and hydration status also matters. In teams and athletes alike, prevention depends on heavily guarded hand washing routines, cleaning shared surfaces, and keeping symptomatic individuals away from shared environments until they're clearly improving. Rabies is rare, but one that is urgent. The most important point is that treatment must begin before symptoms develop. Once clinical rabies progresses, it's almost universally fatal. Rabies is most commonly associated with animal reservoirs such as skunks, raccoons, and bats. After a bite or a concerning exposure, the virus does not simply stay at the wound site. It enters the nervous system, travels by axonal transport through sensory neurons, and in simpler terms, the virus essentially hitches a ride along the nerve pathway. The incubation period can vary widely, often around 2 to 16 weeks, depending on partly where the site of the bite is. A bite closer to the brain can lead to a faster progression because the virus has a shorter distance to travel through the nervous system. Early symptoms or prodromal symptoms can include fever, anorexia, paresthesia at the bite site. Paresthesia refers to abnormal sensation, burning, tingling, or prickling. And that kind of symptom at the exposure site should raise concern in the right context. As rabies progresses, the patient may develop confusion, fatigue, and increased salivation, throat spasms, seizures, paralysis, coma, and ultimately death. The, the classic foaming at the mouth that we observe is actually because the person is producing saliva, but the throat has spasmed and it makes swallowing difficult. Historically, diagnosis has been associated with examination of brain tissue for Negri bodies. But clinically, the key issue is not waiting for dramatic symptoms. If rabies exposure is a possibility, the patient needs immediate medical evaluation. In this case, rabies is not a watch and wait situation. After a concerning exposure, post-exposure protection with passive and active immunization protocols can be life-saving, but only if started before symptoms begin. In our slide on clinical manifestations, we see a transition from infectious disease back into the immune overreaction category. Here we're summarizing several IgE-mediated allergic reactions, and this includes systematic anaphylaxis, acute urticaria, allergic rhinitis, asthma, food allergy. And the main point is that the symptoms can reflect the host immune response just as much as pathogen or exposure itself. In an IgE-mediated reaction, the body is responding to something it's identified as an allergen. That could be food, medication, insect venom, pollen, and animal dander, or another trigger. A helpful way to think through this slide is to ask three questions. What's the allergen? How did it enter the body? And what response did it produce? For example, inhaled allergens may contribute to nasal symptoms or asthmatic responses, while orally ingested allergens may cause gastroenteritis symptoms or gastrointestinal symptoms, hives, or severe cases, anaphylaxis. This also reminds us that asthma can overlap with allergic mechanisms. Some asthma is IgE-mediated, and exercise-induced symptoms may look similar on a clinical standpoint because both can involve airway inflammation, bronchoconstriction, and difficulty breathing. The clinical thinking point here is that not every rash, wheeze, or inflammation or inflammatory symptom is infectious. Sometimes the dormant mechanism is just an allergy. Sometimes it is inflammation. Sometimes there may be overlap. So the key to keep in mind is that symptoms may often reflect the immune system's response, not just the original trigger. So we might need to investigate or ask additional questions as we're trying to identify the root cause of whatever the mechanism is causing in terms of signs and symptoms.